Welcome to Knowledge on the Go, the podcast brought to you by the Performance Improvement Programs team at Vizient. Today, we'll examine what healthcare systems and chief quality executives should consider when setting up their system-wide quality structures to ensure foundational components are strong enough to allow executives to focus on more innovative areas of healthcare. Joining me is Dr. Matthew McCambridge, the Senior Vice President and Chief Quality and Patient Safety Officer at Lehigh Valley Health Network. I'm Amber Hanser, Senior Director of Performance Improvement, and your host. Welcome to the podcast.
Thanks, Amber. Great to be here.
Dr. McCambridge, a recent Vizient benchmarking survey assessed 48 organizations on their system level and system-wide quality structures, looking at the representation, the role, and the influence of the system quality executive. 42 of the 48 health system respondents had a system quality executive role within their organizations. And of those 42, they showed slightly better quality outcomes related to complication rates and readmission rates. The organizations without the SQE role showed variability in the outcome metrics listed. How do these survey results resonate with you?
It's good to see those survey results. That's what you hope for somebody in my role. A lot of us have a bunch of different hats. In my role, first at Lehigh Valley and now Lehigh Valley merged into Jefferson, what I have under me tends to be quality, patient safety, infection control, infection prevention, all regulatory matters, accreditation matters. I have radiation safety, which I think I'm one of the only CQOs in the country that has that. But then there's this massive bucket in the quality world these days, which is all other duties as assigned. It doesn't surprise me. The survey showed that somebody who's keeping an eye on all that. One of the things that's important for CQOs and for an ROI on CQOs is pay for performance programs that are out there right now, or value-based care. It's helpful for somebody to be at the middle of all of that. Having said that, the bigger you get, you can't really do it without like a hub and spoke model. I remember when I was a chief quality officer for only 2 hospitals, you could be the chief quality officer and didn't need much of a spoke arrangement because you could do it all. But as we've gotten so big, now we're 32 hospitals and 700 practices, it's helpful to have like a hub and spoke model. There's a central hub region that's keeping an eye on everything. And then there's people out there in the regions that are driving the performance.
When we think about system-wide governance and system-level governance, the hub and spoke model means that there's alignment. One of the questions that we'll probably get when we share these survey results out with the larger membership is, how would a system assess if their structure is strong and is able to support clinical performance and reliability or accountability? Is there a way in which organizations can assess that?
I've been a Vizient member now since 2010. As Vizient has gotten more mature and the CDB has gotten more mature, the benchmarks have gotten to be really good. How do your outcomes benchmark against the rest of the country? When you look at the top performers and you look at things like mortality and length of stay, readmissions, the big things, they tend to do pretty well in those categories year after year. What they've done is that they've benchmarked all those things and they've changed their structure. There's this whole concept from the board all the way to the bedside. Many of those same organizations that have system chief quality executives, they also have a board subcommittee on quality and safety. Those two things are important because the board, we're all holding each other accountable at the management level, but then the board holds us accountable. And that information then goes all the way down to the bedside and then goes back up. That's the way it kind of works best.
One area that the survey asked was around the qualities team or the quality executive's role in mergers and acquisitions. How do you assess if an integration is going to be successful or not? Is there anything that the subcommittees look at specifically when you're coming from a health system that's integrating more than one organization? Is there anything that you guys kind of looked at from a governance perspective?
One of the things that was really helpful for us, both at Legacy Lehigh Valley Health Network, when we were integrating with other hospitals, other smaller health systems, and then forming together, now that we've merged into the larger Jefferson, is that both entities, Lehigh Valley and Jefferson, were already on Vizient. Both were interested in quality and safety. And the first time we met with the management team down at Jefferson, they got up in front of us and they shared their top priorities. And the number one priority was quality, safety, and equity. You can kind of tell that in the data. They're trying to be the best at getting better. We were both on the same EMR. That helped. There's a lot you can do prior to a merger and an acquisition. It's more than just looking at the leapfrog scores, looking at the star ratings. If you're both in Vizient, then you can drill down to everything from the big 3, mortality, length of stay, and readmissions, to all the way down to things like nursing home discharges to home, physical therapy utilization. Happy to say that we were really, really well aligned.
I would imagine being able to benchmark each other across the same metrics, same methodology in real time. Yeah, that has great benefit. When we think about quality structures, are the actual functions in which roll up to quality. We've heard a lot repeatedly, even before the survey and throughout a lot of our work, that the quality teams need more support, but they have a really hard time securing more staff. How should a system or a chief quality executive start thinking about that differently?
I read a book by an ED doctor. Her name was Elizabeth Rosenthal. She wrote a book called An American Sickness. There's this whole concept of there's two different sides of healthcare. There's the Mother Teresa side of healthcare, and there's the Goldman Sachs side of healthcare. As chief quality executives, you kind of have to find that spot in the middle. Many of us may be more aligned on one side, like the Mother Teresa side, but one thing I've learned, you have to find the spot that's in the middle. There's often this expression in healthcare, no margin, no mission. But there's also an expression, no outcome, no income. If your outcomes aren't where you want to be, then maybe your finances won't be so great. You have to find that balance. That's been one of the changes over the last 5 years, has been more and more difficult to financially be positive. You have to be financially sound. You have to be financially positive, or else it's hard to invest in quality and safety. It's hard to pitch that. In general, around the country, quality and safety in regulatory infection control, we tend to be fairly leanly staffed. But at the same time, the management teams realize it's important. And if you can't have a certain amount of staffing that in quality and safety, then you're probably going to be impacted on other things. Patient experience might not be as good as you want it to be. The finances might not be as good as you want it to be. So it's all related. And you have to kind of find a balance. I saw the results of the survey, and we're all structured a little bit differently. I think one thing is very true, that in 2025, we're all reasonably lean in quality and safety. That's the way you're going to see it moving forward. It's not like the people in human resources and finances and all those other areas. It's not like there's a whole bench of those people either. Healthcare has become quite lean. The future of quality and safety staffing, it's going to be, we have to learn to do each other's jobs. So I think long gone are the days where you're kind of just like that patient safety officer, or you're that quality person. If you're a quality person, that may be what you do 90% of the time, but you may have to chip in on regulatory things. You may have to chip in on patient safety things. And I think vice versa for the patient safety people. And that's what you're going to see moving forward, is it's going to be lean. The people are going to be cross-trained. Those staff members, the ones that tend to do really well, are the ones that can teach themselves new tools.
Quality teams and quality executives are often overseeing a lot of things, even though they may not be directly responsible, and that there's a real opportunity and power when it comes to quality executives around how they lead by influence. I was curious if you have any thoughts around how there really is that innate power with a quality executive across their peers and with their CEO.
Quality executives tend to have like a small team directly reporting up through them, depending on how big your organization is, anywhere from just a handful of people to like 100 people. But then you're matrixed to literally thousands of other people. None of those people are directly reporting to you, and you're trying to get them to see the world the way you see the world. You're trying to lead by influence. In the quality and the safety world, you have to pick and choose, and you can't be asking for help on every last topic. You have to pick and choose your topics carefully, prioritize them very carefully. You have your own team, but then you're trying to get other people to come along with you. For instance, care management doesn't come up through me, but they're really, really important in what we do. Working with our colleagues in those areas to work on projects together. And I think that's going to be the future of the healthcare executive as well, is try to understand the big picture for other people and then work together in teams to make things better.
There's a lot of exciting work coming out of the future of the quality executive. And we say you have to have the right mix, the staffing, the governance, the oversight, the influence. Are there any other foundational components that you think it's important?
I went back to school when I was older and got a master's in healthcare quality and patient safety. And the first class you get was, they talk about structure, process, and outcomes. You have to have your Don and Beedian approach to quality, the structure right. Your financial structure has to be good too. You have to be solid on all of those different areas before you move on to the really cool stuff. This is a really exciting time to be in healthcare. There's so many cool things happening. It's easier to bring those cool things to your organization for the patients in your community if your whole platform, if your whole structure is solid. There's been so many advancements in technology, robotic surgery, telemedicine, wearable health devices. I got a continuous glucose monitor on my arm right now because I want to see what it does to me, right? There are a lot of wearables, and then personalized medicine. So to bring all those things into your organization, it helps to be sound not only in the quality and safety world, but also in the financial world. I was an intern and a resident at a time when there was new horizons for HIV, getting that terrible disease under control. The weight loss drugs are really remarkable. The congestive heart failure drugs right now, they're amazing. The gene therapies, the immunotherapies, regenerative medicine, cellular therapy, gene editing. I mean, it's amazing what's happening right now. The artificial intelligence that's overlaying on top of all of that. As a chief quality executive, our role is to make sure that the quality and safety are foundational, to make sure we're providing as safe as possible care to all of our patients. And once that's all in place, then you can build on that and bring all these other things into your organization.
It's the components to a good soup. And then you got to make something creative and start cooking. I really liked the concept of structure, process, outcomes, and leading by influence. But another piece that you kind of mentioned was leading with data, not drama. What does that mean to lead with data, not drama?
When you're talking about certain topics, they can be triggering to the people you're talking to. I know that's true with me. It's important to try to be responsive rather than reactive and try to be aware. There's certain topics that are emotional. We take care of patients and some of the topics are sensitive. One of the things that's been helpful over the last, again, 5 to 10 years, particularly with Vizient and particularly with the CDB, is looking at what the data shows. I used to be 10 years ago when I started doing this work full time, the doctors back then would question the data. There would be a lot of questions about the data, this data is no good, or how did you get this data? Now, the sources are solid. The data has gotten to the point, the benchmarking has gotten to the point where it's so solid that you can just show the data and there's not a lot of questions about the data. And if you're drilling down the data, whether it's C-section rates or readmission rates or antibiotic prescribing in primary care practices or adenoma detection rates for screening colonoscopies, there's a metric where you can get the data down to the individual level and just kind of show the data and have an honest conversation about it and non-judgmental.
Opens up the door for conversation to understand more without bringing in more sensitive or emotional provoking reactions. Thank you, Dr. McCambridge, for joining us and sharing your insights. And thank you to all of our listeners for taking the time to join us today. Please join us for more Knowledge on the Go podcasts. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com. For Vizient's PI programs team, I'm Amber Hanser. Have a great day.